All right, so we'll pick up where we left off, roughly, talking about reabsorption. So as soon as everything goes out, we need to get back. So we shovel that fluid out, the filtrate, out in that capsular space. It's in the capsular space, and then we're immediately going to reabsorb most of it at the proximal convoluted tubule. About 65% of sodium and water gets reabsorbed, all the organic nutrients. And the thing with the organic nutrients is this is the only place, the proximal convoluted tubule is the only place we can reabsorb those organic nutrients. If we exceed that transport maximum and we go past the proximal convoluted tubule, there's no other mechanism to reclaim any organic nutrients past this point. So glucose, amino acids, etc. If it gets past the proximal convoluted tubule, we can't do anything about that. So this is where all that gets reabsorbed. Ions, tiny proteins that happen to filter through the filter, all of that gets reabsorbed here at the proximal convoluted tubule. Past the proximal convoluted tubule, we enter the loop of Henle, or the nephron loop. And it has a limb that goes down deeper in the medulla, sometimes much deeper, and then a limb that comes back up. So a descending limb and an ascending limb. The descending limb, as we'll see in just a bit, is only permeable to water. And the ascending limb is permeable to certain ions. And this creates a mechanism that we'll look at in just a bit. But here we're reclaiming more of the water and more of those electrolytes. And then finally we enter the distal convoluted tubule and the collecting duct. This is our last chance to reabsorb anything, and the reabsorption of stuff here is regulated by hormones. Calcium reabsorption is regulated by parathyroid hormone. Water reabsorption by antidiuretic hormone. And sodium reabsorption by aldosterone, and to a lesser degree, an atrial natriuretic peptide. Aldosterone is a steroid. Steroids act directly on DNA and cause the expression of some protein. And here, that aldosterone causes the expression of proteins in those distal convoluted tubule cells. So if you've got your distal convoluted tubule cell here, filtrate here, blood here, what this is doing is it's causing the cell to express more protein channels on the luminal side, so on the filtrate side, and it's expressing channels for sodium. There's a lot of sodium out here, so sodium wants to go in, and potassium wants to go out. And then on the other side, it's expressing those sodium, potassium, ATPase pumped. So that sodium that comes in gets pumped out. You get 3 sodium out, 2 potassium back in, leaks out the other side. So aldosterone, we're going to reabsorb sodium, and we're going to excrete potassium. And it does this by causing the protein to make those membrane channels or pumps. Secretion is the opposite of reabsorption. Secretion is getting rid of stuff. Secretion is what we're doing here with potassium, for instance. We're moving it from the bloodstream into the filtrate. So potassium, those hydrogen protons, that's ammonium, nitrogenous wastes like ammonium and some other things that we'll look at in just a second. Drug metabolites, that sort of thing. Those are actively going to be secreted into the filtrate. So this gets rid of potassium, those nitrogenous waste, urea, uric acid, and this is going to be involved in controlling pH, which we'll get to much later. One of the major functions of the kidneys is that, just to get rid of that excess potassium. When people die of renal failure, they don't die because urea built up in the blood. They die because potassium built up in the blood. When you have patients that are in renal failure, there are things that they have to avoid, and mostly things like potassium supplements. There's even a salt substitute that instead of sodium chloride, it's potassium chloride. And they have to avoid that as well, because that excess potassium can't be eliminated because their kidneys suck. All right, so we regulate the concentration and the volume of the urine, and those two things are the same thing. Because water follows stuff, right? Water does osmosis. Water moves to the area where there's more dissolved particles. The number of dissolved particles in water is measured as osmolarity. Anytime you see osmolarity, osmolarity is a measure of concentration. And water moves toward the area of higher concentration. Water moves toward the osmoles. Water moves where there's more stuff. If there's more dissolved stuff on one side, water's moving that way. And this is how we move water. We move water by varying concentration. We don't have pumps for water, we have pumps for sodium. Water follows it. The osmolarity of body fluids is expressed in a milliosmol. The osmolarity of your plasma is about 300 milliosmoles. And the way that this is maintained at the kidneys is using something called a counter-current mechanism. We have one tube here in the nephron, but when we get to that nephron loop, one segment goes down into the medulla, and then it turns around and comes back up. So fluid is moving down on one side of the tube and up on the other side of the tube. That's countercurrent. Countercurrent is when fluid is moving in opposite directions in two segments of the same tube. So you've got this loop that goes down. Fluid is moving down on one side and up on the other side. This countercurrent mechanism is a self-perpetuating cycle, and we're reclaiming water and we're reclaiming ions. The reason we're reclaiming water is because we're reclaiming ions, and the reason we're reclaiming ions is because we're reclaiming water, and it's just this vicious cycle that never ends. The reason this happens is to establish that osmotic gradient so the kidneys can vary the concentration of the urine. So as we think about concentration, remember what we're talking about here. We've got water with stuff dissolved in it. If we take away the water, we still leave the stuff. So, like if you take tap water, especially like here, and you put it in like your iron or your humidifier or whatever, or you just boil it, what happens to that tap water if you just boil it? What do you start to see? Little white particles start to form. You boil it down to dry, like it'll leave a white film on the bottom. So like your humidifier will do this, like you'll see stuff floating in there. What's happening is that you're increasing the concentration of the water because you're getting rid of the water. You can't boil off all that crap that's in our tap water. It stays behind, but the water evaporates. So if we get rid of the water, we still leave the stuff. And that's what we're going to do here in the kidneys. Because here at the nephron loop that makes this loop that goes down and back up, part of that nephron loop is permeable to water. The descending limb is only permeable to water. So that means that as this fluid goes down, the water goes out, but the stuff stays behind. It can't escape. So that means that the concentration, as we go down to the bottom, the concentration goes up because we got rid of all the water. So at the start of this, the concentration is like 300, and at the bottom of this, it's like 1200 because we lost all the water. That means by the time we get to the bottom of this down here is super concentrated. There's like a crap ton of sodium and chloride down here. It's really concentrated. Now, when that fluid comes back up the ascending limb, water can't move anymore. It's impermeable to water, and it's only permeable to these salts, which conveniently there's a lot of there. So now, as we go up, that sodium and that chloride move out into this interstitial space. Normally, what would follow sodium is water, but water can't come out of this side. But that sodium's just hanging out here now. So water can come out of the other side. So because sodium comes out of the ascending limb, it pulls water out of the descending limb, which allows sodium, it's just a cycle. It never ends. And as we come back up into the distal convoluted tubule, the osmolarity goes down to about 100. So this is a much better drawing of that. So here's our descending limb. Water is coming out. The reason that water is coming out is because you've got all this sodium chloride out here. The reason the sodium chloride wants to go out of the ascending limb is because all the water came out of the other side. This never reaches equilibrium. It's never going to get to the point where everything's just cool and equal, because as soon as that water comes out and as soon as that sodium comes out, it's going to re-enter the bloodstream. Because wrapped around this loop of Henle is a blood vessel. Those peritubular capillaries are immediately going to pick that stuff up and get rid of it. So we never reach equilibrium. Urea is also going to move here, and urea is going to help with that concentration gradient. So it's going to help pull water out of that descending limb, so that water comes out and then that lets sodium come out on the other side. Wrapped around this is this peritubular capillary, and in the medullary nephrons, we have this big blood vessel called the vasa recta, and this immediately removes that salted water, so we never get equilibrium, and it's always got this gradient going on, so that we're always reabsorbing the salt and we're always reabsorbing the water. So here's our mechanism there. And so now, right, blood coming in from the blood vessel here, and then our reabsorption of water, kind of the opposite direction there. Okay. As it comes back up that ascending loop, it's diluted, and if we left it alone, that's how it would stay. I'd have an osmolarity of about 100. We're not going to leave it alone. We're going to then remove other ions. Aldosterone is going to let sodium come back into the blood. Parathyroid hormone is going to let calcium come back into the blood. And in the absence of antidiuretic hormone, you might drop the osmolarity here to about 50, which is really dilute. That would be a lot of water. We don't like to waste things. We're going to get that water back. And we get that water back. So here's diluted urine. You can see like large volumes of diluted urine here. That's not helpful. What we need is to reclaim all that water too. That depends on antidiuretic hormone and the osmotic gradient as well, but antidiuretic hormone. So what happens with antidiuretic hormone is antidiuretic hormone opens water channels here in this collecting duct. So, right, there's all that sodium chloride out here. There's going to be urea out here too. Water's coming down this collecting duct, and antidiuretic hormone opens the water channel. So now that water can all come back out and get reabsorbed. You reabsorb the water, and then instead of a large volume of diluted urine, you get a much smaller volume of concentrated urine, and that's what we're going for. We're going for this idea so that we reclaim as much of the water as we can. Now, is it as concentrated as that? Probably not. I mean, depends on your level of hydration. It might be. Like, you don't drink things, maybe. But, I mean, and it might be more diluted than that. Somewhere in the middle is usually where we're going to find this. Not super concentrated, but also not super diluted either. The more fluids you bring in, and we'll see this in just a minute, the more fluids you have to get rid of so that we can keep this balance. A diuretic, and we'll talk more about diuretics when we get to some pathophysiology. We'll talk about different types of diuretics, like a loop diuretic or an osmotic diuretic. An osmotic diuretic is something that can't be reabsorbed, like glucose in a diabetic patient. If we have glucose in this filtrate as it enters the loop of Henle, that's something that's going to pull water back in and prevent it from leaving. So then you create another large volume of diluted urine. Alcohol inhibits antidiuretic hormone. So you can't open those water channels, and the water stays in that collecting duct, and it's going to. So alcohol is a diuretic. Caffeine is a diuretic. Caffeine inhibits that obligatory water reabsorption and sodium reabsorption. There's a lot of other things that will do this as well.
It makes you pee a lot though, right?
Yeah.
It's an anti.
Okay.
So it's opening the
So antidiuretic hormone opens the channels.
Okay.
Alcohol prevents that from happening. So the water has to stay inside.
Okay. So when it keeps filtrating, is it just leaving that crap behind though? Is that?
It's leaving the water behind.
It's leaving the water. Okay, so when we say leaving the water behind, we mean in the urine behind.
Okay.
So, and that does get confusing because we're talking about like reabsorbing and what's in the tube and what's out of the tube. Anything that's in the tubule is going out.
Okay.
Like it's leaving your body. Like when we say it's staying in, we mean it's staying inside the renal tubule system, so that's urine.
Okay.
So
That's what I was-
reabsorption, like when it leaves the renal tubule system, it's coming back into you.
Okay.
So like antidiuretic hormone is opening the water channel so the water comes back into the blood.
Okay.
If we block that antidiuretic hormone here, then the water has to stay inside the tubule system, so it's gonna be in the urine.
Okay.
So, you're aware, this, like, alcohol's a diuretic, breaking the seal, right? And then you're constantly peeing as you're drinking, because the water there's also just going through you. Alcohol will also dehydrate you in a hurry. And then this is one of the issues, with, your drinking problem, is that it dehydrates you. Because we block that antidiuretic hormone. Alright, so big picture, proximal convoluted tubule. That is bulk reabsorption. We're gonna reabsorb as much as we can, like 65% of the stuff that we just threw out, we're gonna bring back into the bloodstream. The descending limb of this loop of healing, we're gonna reabsorb water. And the ascending limb, we're gonna reabsorb some more salts. The distal convoluted tubule is fine tuning. It's hormonally controlled. We're gonna reabsorb some calcium and probably some sodium and some water with that. And then finally, the collecting duct. This is our last chance to reabsorb sodium, to reabsorb water. And it's gonna be involved in pH regulation, which we'll talk about later. Renal clearance is the volume of plasma that's cleared of something in a given amount of time. We use renal clearance tests to determine your filtration rate. And from the glomerular filtration rate, we can track the progress of any sort of kidney disease. So the way that we would measure renal clearance is we're gonna pick something that gets through the filter, but then the kidneys just don't care about it. It has to be freely filtered, but then after that, we don't actively like, oh, we want that back. And we don't actively like, oh, we need to pump that out. It's just, it got through the filter, screw it, we don't even care. So something like, okay, so here's the renal clearance, whatever, there's math, moving on. So for anything that's that's freely filtered, and the kidneys don't care about it after that, there's no mechanism to reabsorb it, and there's no mechanism to actively throw it away, the renal clearance is exactly the same as the filtration rate. How much of that insulin, for instance, is in your urine? That's how much the kidneys are filtering. If the renal clearance is less than that, that means you're reabsorbing it. If the renal clearance is 0, that means that you reabsorb all of it. So something like glucose, 0. You reabsorb all of that, assuming you're not diabetic. If you're diabetic, it's not 0. If it's higher than the glomerular filtration rate, that means that not only did you not reabsorb it, you're actively throwing it out. It went through the filter, and you're sucking it out of the blood too to throw it into the tubule system as you go, because you super don't want it. So like drug metabolites will be actively secreted and have a really high renal clearance, so you can get rid of that. All right, so urine. You've seen urine. Urine looks like pee, right? What is that? Is that pee? Probably. It's urine. Things can change the color of urine. There's an over-the-counter supplement that you buy for a kidney infection or a bladder infection that turns your urine bright orange. That crap will turn everything bright orange, like your fingers, whatever. There's a medication that will turn your urine kind of a blue-green. This is why I don't have a license to practice medicine, is because I would abuse that. I'm like, here, take this. 5 seconds later, it turned my pee green. What?
Dude, that's crazy.
So yeah, I would totally do that because that's evil.
That's scary.
Like cloudy urine may indicate a UTI. That's cloudy urine. That's pus in the urine, because you've got yeah,
Say puss.
yeah,
That's what the cloudy is?
yeah. It's infection. Not good. Not the best.
Oh, man.
That doesn't have to. Like maybe I don't know. There's some things dietarily that will do this. There's some things dietarily you can do that will make the urine kind of foamy, but that might also be proteins in the urine, which is not great. Urine, it smells like pee. If you have children, you're aware of this. This is my favorite slide ever. I stole this one. Slightly aromatic. I was like, no, it smells like pee. If you have animals or even kids, like if you leave that urine there, eventually you get that ammonia smell. That's because that ammonium ion gets fixed by bacteria into ammonia, and then you can smell it. So if you've ever had like livestock or even a fish aquarium, like you have a fish aquarium, like you have to constantly monitor ammonia levels because the fish are peeing in the water, and it will turn into ammonia. So you have to manage that. And you
Like
can
a pool, like a public pool?
no, that's way too diluted.
Really?
Yeah, like there's a
There's so
bazillion
much
gallons of water.
in there.
There's so much bleach in there, you don't have to worry about it. There's like, don't get me wrong, in a public pool, like there's totally a kid that's peeing in that pool like right now. At any given point, like how do you know that happens? It's always happening. Like you're swimming in a giant thing of urine. Just get over it. It's also full of bleach, it'll be fine. Like it's so diluted though, it's like I mean, I'm not saying it's the ocean by any means, but like if you're swimming in the ocean, like you're obviously swimming in fish pee, so I mean,
Same thing.
and whale pee and like dolphins, like I mean, it's water.
How come I never think about
Now you're thinking about that with the ocean, you're like, wait a minute. The ocean's gigantic. Like how many whales could possibly be peeing right now? There's probably a lot. And there's a lot of fish, right? Now, and like other animals and people, like, and we're dumping waste into the ocean. Hey, it's not the best water. Let's go swimming anyway. Alright, the pH of urine, like 6-ish. It can be more acidic. If it gets down to like 4.5 range, it's not gonna be fun. Like it's gonna burn because it's super acidic. If it gets up to like 8, higher pHs like that typically indicate some sort of urinary tract infection. It should not be that alkaline. You can throw off the pH of your urine, and we'll talk about that in terms of balancing pH later. The specific gravity is a measure of how much stuff is dissolved in that, and usually it's between like 1.001 and 1.035. Water has a specific gravity of 1. So that's slightly more concentrated than water, not a lot. And actually, that's because it's like 95% water. There's like 5% stuff in your urine, like waste products, urea and uric acid, creatinine, these fun electrolytes they'll find in the urine. That's pretty much it. Most of it's water. When we do urinalysis, we look for abnormal things here. We look for things like glucose and protein and abnormal concentrations of any of these electrolytes to indicate some sort of pathology or dysfunction in the kidneys. You ever watch those survival shows on whatever stupid travel channel you've got? Like, what is it, Bear Grylls? He's like, you can drink your own urine up to 3 times. Don't try this. And he's like, I'm like, do you have like, is there like a study for that, or just like based on your own life experience? Like,
I just tried it.
like why is 3 is a very specific number, right? Like, it's like,
Well, after
it's like,
4 is
it's like the 4th time it'll make you sick. I'm like, really? Like, is this like, I didn't see the research, and that's awful. So yeah, I'm like, dude, don't pretend like you're really like out here surviving. Just,
Drinking how much will
Don't
do what?
pretend
Do you know
you're
that
bigger
show that they
survivor.
have that weird addiction and they drink their pee all day long?
well, so eventually what happens is that the concentrations are going to start going up because you're re-ingesting those nitrogenous waste products, which are immediately going to be secreted again, and you start getting that, it gets more and more concentrated if you're not diluting it with water. And it gets more and more concentrated. So yes, eventually it will be mostly toxins. But, you know, I guess if you're on the ocean, or no, don't drink pee. Like, why don't we even talk about this? Like, there's water everywhere, literally everywhere. You can just walk to the back of the classroom. You're fine. You know, why are we even worried about this? We used to do urinalysis in lab, and we use fake urine. Okay, so we use fake urine. But I didn't tell anybody it was fake urine. ever. And one summer, we got the things in, and like I had the kid or whatever, and it was hot, right? So I filled up these little test tubes, and the fake urine in there was hot. Like not even like warm, like it was quite warm. And so immediately they picked up a tube and they're like, oh wait, because like it wasn't just urine now, like it was like fresh urine, and they were like, and then I realized what they were freaking out about, and so then I started spilling it on purpose. I was like, oh, and it spilled everywhere, and then I just like wipe it off the table and just, because it's just water. It's just water
Like
with color in it, and maybe like glucose molecules for you to detect with the test. And it was, so yeah, that was my favorite student evaluations ever, because my department chair called me in and was like, so one of them says, he kept spilling pee and not washing his hands. And I'm like, that is my favorite. I'm like, he's like, so I explained it to him. He's like, you didn't tell them it was fake? I was like, no. I like that the whole semester after that too. He's like, you never told them. I'm like, no, that would have ruined it. So yeah, and so we were talking, and he told me that when they used to do it, they used to use real urine. Like he's like, go pee in the bottle or whatever, and they'll just test your urine. And I'm like, yeah, I have a line somewhere. Yeah. I've always wanted to bring in like that drug test thing though, and like just what we're doing today in lab, and people like, walk out the back.
I don't want to. Oh, thank you.
All right, so from the kidneys, as we exit the renal pelvis, we enter the ureter. From the renal pelvis, so once we enter that minor calyx, from the renal pelvis out, that's it. Like if it enters that minor calyx, it is urine, it's going out. There's no mechanism to reclaim anything from this point out, it's just a tube out. The ureters are the tubes that go from the kidneys to the bladder. They're still retroperitoneal, just like the kidneys, and they go through the posterior wall of the bladder. And as the bladder expands, it bends the end of the ureter so that it prevents urine from going back up and into the ureter. You don't want backflow there. There are 3 layers of the ureter. It is a smooth muscle tube. So it's flat. The inner layer is epithelial tissue, transitional epithelium, the stretchy one that changes shape. Then there's smooth muscle, and that smooth muscle contracts when it's stretched out. So that as fluid goes through there, it pushes the tube open, and that tube contracts just like any other sort of tube, and it's going to keep pushing that urine down toward the bladder. It looks like that. Okay, so this tube is by no means meant to move anything that's not liquid. Sometimes that happens. Kidney stone or renal calculus is when stuff crystallizes in the renal pelvis. Maybe it's a calcium magnesium salt, maybe it's uric acid. Kidney stone's different. And if they're big enough, they'll actually block the ureter, and then pressure builds up in the kidneys, and it can cause extensive damage there. What causes kidney stones? Like chronic UTIs, hypercalcemia from like hyperparathyroidism. If the urine is too alkaline, keeping the urine acidic helps dissolve those minerals in the kidneys. Your development of kidney stones is also correlated with your like beverage intake, right? So if all you drink is like solid Dr. Pepper, or pick a it doesn't even have to be like full on like, you're like, I drink Diet Dr. Pepper, whatever. It's still that carbonated beverage tends to lead to the development of kidney stones. You should really drink, more water. If it blocks the ureter, there are multiple things that we can do there. So we can go through and surgically remove that. There are non-surgical alternatives. There's what's called the lithotripsy, where they use ultrasound to break up the kidney stone so that it can keep going. If it's like blocked and pressure's building up in the kidneys, they can go into the ureter and put a catheter in like this in the ureter. So like that's from the kidney down to the bladder. And now that I think about it, like this came out as a student, then I should probably wash my hands. They gave it to her, and I was like, she gave it to me, and I was like, oh, cool. Whatever, it was inside. It's fine. Like that's not they put like a dirty tube in somebody, right? Like it's like Why would they do that? That's just gonna ask for
Is
infection.
it the one that blows up the little balloon?
No, like that, okay, so, and if you look at this tube, like, it's got tiny little holes in it, and so, that's going from the renal pelvis all the way down to the bladder, so that fluid that's in the ureter can come into this tube and escape all the way down to the bladder without building up pressure, until they can remove whatever obstruction is there. Kidney stones come in different forms. The little magnesium, calcium ones tend to look like little rocks, and the uric acid crystals tend to look like, shards of glass. These are probably calcium magnesium stones.
Those are actual ones?
Yeah, somebody brought me those too.
That's pretty gas, honestly.
Like,
I found out some.
they were fresh when I got, she brought them in that morning, and she's like, I had a patient pass these this morning, and I thought you'd want them. I'm like, hell yeah, I want those.
Oh my gosh.
And I'm like, that's
Are
a
these
lot
ones
of,
they had to have,
like,
surgery
that,
for?
no, like,
They just
passed those?
yeah, he peed those out.
Oh my god.
I'm like, so what's the story here? And she's like, this dude comes in like once a month, and he's like, I've got kidney stones again, and then he pees them out, and there's like a bunch of them in there, and I'm like, wait, this is one sitting? And she's like, yeah, and I'm like, that says a lot.
I would just What is die. it? I would die.
I don't know what the guy's doing with his life, but if,
I can't even handle like a UTI.
Yeah,
How
no.
much is that?
Some rocks coming out of you.
so kidney stones are supposed to be super painful, and it's not the passageway out, it's this movement. It's from the kidney.
It's like what you can feel it like in your.
It's from the kidney to the bladder. And if you look at those uric acid crystals, like the uric acid crystals look like little ninja stars. And it's got to go,
That's why they have to break them up sometimes.
it's got to go through this tube. And as it goes through that tube, whether it's a rock or it's like a jagged, shard of crystal, that tube contracts around that. It contracts when it's stretched out. That's going to hurt. And it may cut up in the inside of this tube. You may have blood loss there, like blood in the urine as it's going through. It's supposed to be really painful. Patients that have kidney stones, super painful. Everybody I've ever seen with a kidney stone, it puts the fear of God into them.
Yeah.
One guy that I saw had a kidney stone, he thought he was dying. Like, he did not know what was wrong, but he was pretty sure he was dying. This was on a school trip, so much so that he let, it was like an 8th grader, he let like a 12-year-old kid drive him to the hospital because he thought he was gonna die. Have you driven a car before? Nope, let's go.
Let's do it.
When my dad had a kidney stone, again, fear of God, like that guy did not drink a soft drink for probably 3 or 4 years after that. He's like, no. So yeah, it's supposed to be really painful. And then of course your peeing out rocks is not going to be comfortable at all. So yeah, avoid this, drink more water, whatever. Once it gets to the bladder, there's this smooth muscle bag for urine. It's still retroperitoneal, it's pelvic floor. And males, you've got a prostate gland that surrounds the bottom of the bladder where the urethra starts. Trigony is this area where the ureters come in and the urethra is going to exit. We'll look at this picture in just a second. UTIs tend to live here because like a urinary tract infection is coming from the outside in. The bladder's got 3 layers of smooth muscle. The inner layer is transitional epithelium, and if you'll remember, transitional epithelium is the one that stretches out, so it changes shape. It looks kind of columnar, it looks kind of cuboidal, just depending on how stretched out it is. So here's the bladder. When the bladder's empty, it collapses, and we see the wrinkling on the inside. The wrinkles on the inside of the bladder, or the stomach, or whatever hollow organ, if it's all wrinkled on the inside, those are called rugae. And when the bladder stretches out, those rugae stretch out as well, and it becomes more smooth on the inside. This area right here is where, and you can see the entrance for the ureters on either side, and then there's your urethra going out. So as the bladder fills up, it kind of pinches that area off so that urine can't go back up and into the ureter. Infection tends to persist there. Urinary tract infections are more common in females than they are in males, because that urethra, the exit out, is a much shorter trip for bacteria. For males, it's more difficult to get that far. So they're just that distance there. UTIs aren't impossible in males, like it's not uncommon at all, but they're much more frequently seen in females because of this. The urethra is a tube that goes out. There are 2 sets of muscles here that controls urination. A sphincter muscle is one that's round, like makes a circle. The fascicles make a circle. There's an internal muscle, the internal urethral sphincter is involuntary. It's right next to the bladder, and when it contracts, it opens. So it's involuntary, that means it's controlled by the autonomic nervous system. The external urethral sphincter is voluntary muscle, it's skeletal muscle, somatic motor branch. That's the one that's voluntary. So, like actually urinating is going to involve multiple parts of your nervous system. Alright, so female urethra, male urethra, there's female urethra, male urethra. We'll look at this more when we get to reproduction. We'll talk about the different regions of the urethra there. Alright, so urination is going to involve contraction of the bladder, opening of the internal urethral sphincter by the autonomic nervous system, and in an adult, opening of the external urethral sphincter by the somatic motor branch. So all three events are taking place at the same time. In infants, that's not how this works. And if you've had kids, like freaking babies pee all the time. And the reason that happens is as soon as the bladder starts to stretch a little bit, it causes a reflex to happen, and that reflex triggers the contraction of the bladder, the opening of that internal urethral sphincter, and the relaxing of the external urethral sphincter all at once. And it's just a reflex. There's no control there. And it's not until parts of the brain start to mature in the brainstem that they're able to control this. So usually like 2-ish, 3, somewhere between 2 and 3, that part of the brain starts to mature, and then you have these pontoon control centers and the pons that start to develop, and they're able to control that. When you see these people that are like, oh, I potty trained my kid when he was 12 months old. No, you did not. You potty trained yourself. And like they're like, oh, I recognize, like I know when he's about to pee or whatever, and I take him to the toilet. That's you. That's on you. That's not him. They can't control it at all. Like you can see the signs or whatever, but they have no. It's reflexive urination for them. So between the ages of 2 and 3, this part of the brain develops, and then you can control the act of urination, so that you inhibit that reflexive activity. All right. We're not going to worry so much about development. The kidneys are weird when they develop because like 3 sets of embryonic kidneys form, and then one kind of grows and moves up, and the other just degenerates. But again, we're not super worried about the development of the kidneys. There's that. Babies have to pee all the time because they're on solidly, like it's all liquid, everything's coming in, it's liquid. Their kidneys aren't super awesome, and their bladders are tiny. So, like I said, babies are peeing all the time. For like adults, urinary tract infections are not terribly uncommon. Mostly they'll be in the bladder, and most of those will be E. coli. Any other bacteria may cause long-term damage, especially if it makes its way all the way to the kidney. Most of the time, like, that bladder infection is so painful, and I don't know, the symptoms are so obvious that most of the time people are treated before it gets to the point where it's a kidney infection and it's moved all the way up to the kidneys. And when it does, that can be much more serious. As we'll see when we get to reproduction, there are lots of sexually transmitted infections that also infect the urinary tract as well. Alright, so now we need to talk about some fluid stuff before we head out. So, fluids. Alright, fluids. Babies are bringing in lots of liquid. They're losing lots of liquid. But babies are about 75-ish% water. They're squishy. Old people dry out. You've seen this. I think it kind of crispy, and they're only about 45% water. In between, like females about half, and males like 60%. The difference between water content in male and females is just based on testosterone, like muscle mass. You've got more water content. So I mean, half-ish. But what this means is that infants and old people are much more susceptible to fluid imbalances because they're kind of on the extreme either way. In the normal adult, total body water is about 40 liters. 25 liters of that is inside the cells. That's intracellular fluid. So intracellular fluid, ICF, 25 liters. Fluid in the cells. We have extracellular fluid, all the stuff outside the cells, like 15 liters, the rest of it. For our purposes, we can divide that extracellular compartment up into two things. Plasma in the blood and interstitial fluid, which is in the spaces in the tissues. So if we're doing this, you've got your cell. Right around the cell, our next fluid compartment here, right around the cell, is the interstitial fluid. And then you have the plasma separated here. We're going to get fluid exchange between these three compartments, between the cells, the interstitial fluid, and the plasma. Now, any other extracellular fluid, at the moment, we're not considerably worried about. That would include lymph and cerebrospinal fluid, the juice that's in your eye, in the joints, that sort of thing. Right now, we're not worried about those. All right, so here's our total body water, 40 liters, and this division. Everything's dissolved in water. Solutes are the stuff that's dissolved in water. We divide those solutes up into either being electrolytes or not. A non-electrolyte is mostly an organic molecule. They don't dissociate in water. They do dissolve in water, but they don't dissociate. And when I mean dissociate, I mean coming apart in the ions. So like glucose is like C6H12O6. And if you put glucose in water, it's still glucose. Like it doesn't come apart into positive and negative ions. But if you put sodium chloride in water, which is just table salt, if you put that in water, it does disassociate. It comes into sodium and chloride, those ions. That's disassociation. It disassociates into ions. So that's all the salts, most acids and bases. Even some proteins do some disassociation. It can contribute to this. These are electrolytes, and they're called electrolytes because they're charged, right? They're positive and negative ions. These are the most numerous of the solutes. Now, in terms of like mass, no, but like there's a lot of them. And they contribute more to osmolarity than our organic solvents. These contribute to fluid shifts. When we want to move water in the body, we don't move water. We move electrolytes, and water follows them. Water always moves because of osmosis, and we make that happen by changing the concentration of these electrolytes. We express electrolyte concentration as milliequivalents per liter. A milliequivalent per liter is another measure of concentration, but here we're really measuring the number of electrical charges. For ions that have one charge, it's the same as a milliosmol. If they have two charges, it cuts it in half. We're not terribly worried about this. Each fluid compartment has different ions in it. The extracellular fluid, the stuff that's outside the cells, when we're talking about plasma or whatever, if it's outside the cells, it's got sodium. Sodium on the outside, potassium on the inside. So the major cation of the extracellular fluid is sodium. Chloride just follows sodium around. Chloride balance is sodium balance, so there's your anion with chloride. Inside the cells, we pump that sodium out. Remember, inside your cells, you've got that sodium-potassium pump where you're pumping 3 sodium out and 2 potassium back in. So there's not much sodium inside the cells. There's a lot of potassium in there. And this hydrogen phosphate follows that potassium around. In terms of mass, all those organic things make up sort of the bulk of this. Like in the plasma, and the interstitial fluid, and the intracellular fluid, all of these things are proteins. There's a lot of dissolved stuff, especially inside the cells. As you can imagine, inside the cells, there's a lot of proteins that are dissolved there. In the plasma, we've got all those plasma proteins that are dissolved there. Even in the interstitial fluid, there's some proteins that are out there. So let's look at our distribution here. So plasma red, interstitial fluid blue, inside the cells intracellular fluid yellow. So here's sodium. So sodium, you can see like there's a lot of it in the plasma, there's a lot of it in the interstitial fluid, there's not very much inside the cells. Potassium is the exact opposite, not very much on the outside, not very much in the interstitial fluid, not very much in the plasma, tons of it inside the cell. That chloride and hydrogen phosphate, those follow the same patterns. Here's magnesium. Magnesium, you can see there's quite a bit of it inside, but not so much outside. And then here's calcium. There's a little calcium in the plasma. There's a little calcium in the interstitial fluid. In the cytoplasm, there's not really a lot free floating. There's 4 pounds of calcium in you. Where the hell is all the calcium? In your bones. It's not in fluid at all. It's stored in the bones. So the extracellular matrix of bones is not a fluid, it's a solid. So it's tied up there. And what little calcium we have circulating, the vast majority of it's in the plasma and in that interstitial fluid. Not so much just free floating inside the cells. Here's bicarbonate, and you can see it in the plasma and inside the cells. And then these protein anions down there. So this is a nice little chart that shows this concentration of the different solutes through these different fluid compartments. Movement of fluids is regulated by pressure, both hydrostatic pressure, which is blood pressure, and osmotic pressure. When we talk about water movement, we're always looking at osmotic pressure. So we've got these three fluid compartments. The fluid here, the concentration is almost always really freaking close to equal. That's called isotonic. If you remember back to AMP1, tonicity is the ability of a solution to cause osmosis. If we say we're in an isotonic solution, we mean that we have the same number of solutes on the inside as we do on the outside. And these three compartments are roughly isotonic. So what that means is that water goes in and then it comes out. Either way. You get substantial two-way movement, but there's not a net gain or loss. Water moves that way, water moves that way, it's cool. We're swapping back and forth, nobody's gaining anything, nobody's losing anything. When we want to move, we want to gain or lose water, we do that by moving electrolytes. We move some solute, and then water follows that. Also add, like the outside here. There's not substantial two-way movement there, unless we go like zoom way out. If we zoom way out, there is, because you're constantly losing water and you're constantly bringing it in. And you can see here like oxygen in, carbon dioxide out, nutrients in, waste products out. But water, it's two-way movement. In and out. Your water intake equals your water output. Roughly 2,500 milliliters a day is what you're gonna lose, and it's what you're gonna bring in. We bring in water mostly through drinking, but also through eating, and we also have what's called metabolic water. Metabolic water is based on that reaction. We take glucose, oxygen, and ATP, carbon dioxide, and water. That's metabolic water. Then we're losing water. You lose lots of water through urine, sweat, fecal matter's got water in it. And then we have what's called insensible water loss. Insensible water loss is water loss that you don't realize is happening. Water's evaporating off the surface of your skin, and every time you exhale, you're losing some water vapor. Here's our breakdown there. So here's intake, right? Most of it through drinking stuff, eating, and then the metabolic water. And then there's output. And these things should balance out. the major mechanism for driving water intake that tells you you need to be drinking stuff is the thirst mechanism, and this isn't the hypothalamus. Here I have a typo on my slide, I needed to fix that. Arrows are hard. I have to change the font and everything, it's a pain. Alright, so if the concentration of the plasma increases, remember if we lose water, we leave the stuff, so that increases the concentration. So if the concentration of the plasma goes up, triggers the thirst mechanism. When we say that we're increasing the osmolarity, you can think of that, your blood's too salty. Like it's got too much, it doesn't have too much, it just doesn't have enough water, so you bring in more water. Angiotensin II triggers that thirst mechanism. One of the major, so blood pressure, yes, but it has to be substantial before you're thirsty because your blood pressure's low. One of the major stimulus here for water intake is having a dry mouth. Triggers that thirst mechanism. Alright, so science. Back, it's probably like in the 50s, maybe even before then. So the Russians did this experiment with dogs. And so they took these dogs and they surgically disconnected the esophagus from the stomach and they routed it out of the dog's body. So now anything the dog eats or drinks just falls out beside it. So then they withheld water from the dog, so the dog gets dehydrated, dry mouth, dog's super thirsty. They give the dog water, nothing can come into the dog, right? It's just gonna fall out beside it. But it would drink, and as soon as, and what you would expect is it's gonna just keep drinking perpetually because it's not getting any water in it. That's not what happened. It would drink until its mouth got really wet and then just stop drinking because that stopped the signal. And you do this with patients in the hospital, like that little sponge, like they can't bring any fluids in, like they're not supposed to be intaking anything. But if their mouth is dry, you take that little sponge with water and you get the inside of their mouth wet. And it stops that thirst mechanism so they're not just like suffering from thirst. Because that inhibits the mechanism. So the inhibitory thing there, relief of the dry mouth. Another fun experiment, I say fun, science. The Russians did this. So they took a different dog, because you know those dogs are probably dead. So they took a different dog, they withheld water from it. And instead of giving it water, they just inflated its stomach with air. The dog's not thirsty now. And what happens there is that as those stretch receptors in the stomach are triggered, you were super thirsty before, that stretch receptors trigger, and your brain assumes that you just went and got something to drink, and it forgot. Because obviously if your stomach's inflated, there's something in there, you were thirsty, that's probably, it just puts those pieces together for you. And that will inhibit the thirst mechanism. So yeah, if your stomach's super full of, I don't know, air because someone aired it up with a hose, then you're not thirsty anymore. Science. Yeah, there were some really questionable experiments that were done here. Alright, so there's a person drinking, in case you were wondering what that looks like. You're gonna lose water, without a choice. Obligatory water loss. From the lungs and the skin, you have insensible loss. From feces, there's a minimum daily sensible loss that has to occur here. And in essence, what we're talking about in sensible loss is basically urine. 500 milliliters. If you're not producing 500 milliliters of urine a day, your kidneys aren't doing their job. So like in the hospital, when they're measuring someone's urine output, this is what they're looking for. Like there's a minimum amount of urine output that you need there. And it's 500 milliliters a day. Otherwise, that fluid's not going where it needs to go, and it's staying inside you. We don't, however, have like these mechanisms that are like water detectors. We're not looking for that. Water content is regulated because of sodium content, and sodium content is regulated by the mechanisms to maintain blood pressure. The closest thing we have to something that's like directly in charge of sodium is aldosterone, but even then, aldosterone's there for blood pressure. Sodium's just the mechanism. Water reabsorption is proportional to antidiuretic hormone release. If you decrease the amount of antidiuretic hormone, like with alcohol, you have to pee more, you lose more urine, and body fluids go down. If you increase the amount of antidiuretic hormone, then your urine becomes more concentrated, you reabsorb more water. That antidiuretic hormone is also made in the hypothalamus, it's released in the posterior pituitary gland. And the same receptors there, those osmoreceptors that are looking for concentration, will either trigger the release of antidiuretic hormone or not release antidiuretic hormone. There's some other factors here that can cause changes in antidiuretic hormone, but we're not overly worried about that. Those are mostly pathological conditions. For the most part, antidiuretic hormone is released based on concentration levels. We can screw this up. Dehydration is a negative fluid balance. Alright, so what's happening in dehydration is you're losing extracellular fluid, water. Alright, so here we go. Alright, so here's the outside world. Water, that's here, is going out here. What that does, just like we're talking about like boiling off the tap water, that leaves the stuff, the solutes are left behind. The water leaves, the solutes have to stay here. That means now the plasma is more concentrated. So that means that water from here is going to go out to meet those solutes. Which then means the interstitial fluid, the solutes that are out here, are left behind. Now it's more concentrated. So that means that water that's in here has to go out to meet those solutes. And the cells shrivel up. So now, cells are shriveling up. And we've got a weird electrolyte thing going on the outside because all those solutes are out there. If we're looking at red blood cells, it's going to make them really weird. They're not going to carry oxygen so well. If we're looking at the nervous system, the water's coming out and there's electrolytes out here in the interstitial fluid that are weird, and the nervous system gets weird. So in the initial stages of dehydration, like you're super thirsty, the skin's dry, you're not making any urine. And in elderly patients, especially if you pull up like on the skin that's on the back of their hand, like your skin like rebounds nicely. If they're dehydrated, it's like Play-Doh. It'll just stay there. And so then you want to administer fluids. They start to get confused. As people get dehydrated, they start to get really confused. And eventually what happens is what's called hypovolemic shock. Because you're losing the volume from the plasma. When you lose volume, you lose pressure. So pressure starts to come down. And then, you know, you get that hypotension and they might pass out and eventually die. The solutes that we're concerned about here, sodium. Dehydration causes, in essence, hypernatremia. That's too much sodium in the blood. Now, it's not. It's like, you don't literally have too much sodium in the blood. It's not diluted enough now. You don't have enough water. But the result of that is the sodium concentration is really high. It's like taking salt water and then boiling it and letting half of it boil down. You're left with a lot more concentrated salt water now because the salt can't boil away. The salt can't leave. The salt's stuck there. And now we have hypernatremia. And this is going to cause up neurological issues, issues with the cells kind of shriveling up. Most of the time, when we talk about hypernatremia, it's dehydration. There's some exceptions to this. We'll talk about those next week. We'll talk about like actual hypernatremia, where we're putting too much sodium in the blood. I don't want to say exception. We'll talk about it next week. Okay. Oh look, here's a picture with water faucets. But you get the idea, same thing. Okay. The opposite of this is called hypotonic hydration. So in hypotonic hydration, we're going to do the opposite now. So we got our fluid compartments here. Now here, we're taking water that's outside and we're drinking it really, really fast. And we're bringing it in. So it's getting absorbed from the digestive tract, it's coming in the plasma. That water's coming in here. Now, we're doing the opposite. We're diluting the plasma. So now there's more dissolved stuff in the interstitial fluid, and that water moves here. And to some degree will move into the cells. But you're gonna get a lot of water accumulation out here. That is edema. Edema is the accumulation of interstitial fluid. And it's happening, in this case, because of the excess water intake, and it starts to build up around the tissues. This is also called water poisoning. So if you drink water really, really fast, and a lot of it, do what?
Waterlogged.
So that's the initial phase of it. Like when you're like waterlogged, what do you like feel like?
Like,
And you'll vomit. Like if it's bad enough, you'll vomit. Like your stomach's trying to reject you. It's like stop it. And so the initial phases of it, yeah, you get like nausea, vomiting. But if you keep it in and you absorb that water, you'll start to see some muscle cramping, and then possibly cerebral edema, and you're gonna die. Normally, and to make this happen in a normal adult, you gotta be quick. Like drinking a ton of water really fast and not losing it through it's so fast that your kidneys can't get rid of it. Because like right now, if you're like, I'm gonna down a gallon of water, you're probably gonna vomit. And even if you don't, you're gonna have to pee very quickly because your kidneys are just gonna fix that. But if we exceed that and like your kidneys are like trying to deal with it, but you just keep bringing it in, you're like, I'm gonna drink 4 gallons of water. What happens is you can't deal with it fast enough, and you're diluting that extracellular fluid, and it's building up out here. Not super common in healthy adults. It's not unheard of. One of the more publicized cases of this happened, if you remember, like back in the 2000s-ish, when the Nintendo Wii came out. What is that, like 6, 7, somewhere in there? Like Nintendo made like 5 of them, and they're like, fight for it. And places where like there was a radio station that had a giveaway, and it was hold your Wii for a Wii was the premise here. And so they
Hold your
got
what?
hold your Wii for a Wii.
Don't be for a week.
So they brought these people in, and they're like, okay, here's the deal. Drink as much water as you can. If you throw up, you're out. If you pee on yourself, you're out. It'll be hilarious. So you get these contestants. People are calling in. Like physicians, nurses are calling in. They're like, you're going to kill someone. You can't do that. And they're like, it's water. It's not toxic. And they're like, actually. And they're like, actually, they signed a waiver, so shut up. And so they had this, and they killed the lady. Like, she died of cerebral edema. She didn't even win the Wii.
Oh, shit.
Like, she also lost, and then she died. So like kicking them when you're down. So total waste of time there. But yeah, cerebral edema, because she brought so much fluid in so quickly, and it built up around the brain. This will kill you. More often we see this happening where the fluid balance is precarious anyway. Infants. And we had several cases of this that happened during, it's been a couple of years now, we had that formula shortage. So baby formula, you take the powder, you take the water, you mix them together. People were running short on formula, so what they were doing was they were diluting the formula. And just fun public service announcement, if you have kids, you don't give babies water. Unless you're specifically instructed to do so, you don't give infants water. They're already getting enough water through the formula or breast milk or whatever. They're bringing in their obligatory like intake of water anyway. They're already like 75% water. They don't need any more water intake. So as people were diluting that formula, and they're like, let's just put a little bit in there, it's mostly water now, and they were causing hypotonic hydration. And every year there's always a few fatalities from this where people have diluted it because they don't have access to formula, or they just don't know. But it's not safe to do that, and it can cause this. So the opposite happens here. So hypotonic hydration causes hyponatremia. which is the blood being too diluted. Hyponatremia is nearly always hypotonic hydration. That's not enough sodium in the blood. So when we have like beverages that we're bringing in, like whether it's like Gatorade or even bottled water, you'll notice like bottled water, and there's stuff in it. Like even like Dasani water or whatever, it'll say on the back it's like a negligible amount of potassium chloride has been added for your taste or whatever. It's done so that there's electrolytes in the water, so that we don't get this issue. Gatorade's got a bunch of electrolytes in it. We don't get this issue. You don't drink like deionized water because there's nothing in it, and this can happen faster. So, like I said, normal adult, this is not something that's particularly common, but in infants, when they dilute that formula, yes, or in people that are intentionally trying to make it happen. So there's our swelling up of those cells. Edema is the term that we use when we're accumulating fluid in the interstitial space. We see this in the elderly. In the elderly, what's happened is blood pressure is forcing fluid out of the capillaries. We're increasing the net filtration pressure of the capillaries. So fluid moves out, and it's moving out faster than the lymphatics can drain it back, and so it accumulates in the interstitial space. Old people with high blood pressure, like their ankles swell up, their feet will swell up, their legs swell up. We block the lymphatics, we get edema because we can't drain that interstitial fluid. Even localized, like inflammation, when those inflammatory chemicals are released, the capillaries become more permeable, and that's on purpose. We get this swelling. Edema becomes dangerous when it happens in places like the brain. We get cerebral edema. Because with cerebral edema, we're now putting pressure on the brain. And the pulmonary edema, we're putting pressure back on the lungs. So there are places where edema is definitely more dangerous, but for the most part, we're looking at like swelling of the extremities. Edema of the abdomen is called ascites, and we'll look at that when we get to liver failure. And this is just a giant fluid buildup in the abdomen because fluid can't drain back the way it should because of what's going on in the liver. So one major cause of edema is liver failure. So what happens in liver failure? Okay, so we've got this balance of, right, the isotonic. We're doing the isotonic thing, so we get that two-way balance of water, where water's going both ways. In the plasma, we got the solutes. We got like sodium and whatever, and we've got lots of proteins in the plasma. Your liver makes most of those plasma proteins, albumins. And if your liver is failing, those are gone. So we decrease the osmotic pressure, and now there's more stuff out here, and the water goes from the plasma this way. And it starts to build up in the interstitial space. So we get edema, and that's very common in patients that have hepatic failure. They don't have enough proteins in the plasma, so water moves toward the interstitial space around the cells. And we'll see this, like when we look at hepatic failure, and you'll see the edema of the abdomen that occurs there. It's a lot of fluid that will build up in the abdomen. All right, so this is where we're gonna pause for today. So take a break, come back. The rest of the time then is yours with the kidney boards. We'll do the kidney thing next week, so that you need to be prepared for that one. And then we'll be done with the kidney lab stuff. And